like he is doing in exam. So what we do, we allow him to present a history for first 4 5 minutes till he completes the history. Then we can discuss all the point, all the queries, ask the questions. Then once the history part over, examination, and after completion of examination, same thing. Like in an exam, PG exam, it is more of a PG student, so they will understand. After that, we can also discuss investigation and management. He will also have all the investigation report that he will present after completion of that. So like a PG case, we present in like a exam.
Okay.
Okay. Good morning, seeing you after a long time online. How are you?
Good morning, Am.
Hello. Hey, everyone.
Hello.
Hey, Dr. Ramanna.
Hi.
Good morning, madam.
Good morning, Pankaj. How do you do?
Fine, I am fine. Great.
And good morning to all the consultants who have joined the meeting.
Yeah. Madam, I have retired, by the way. You must have known that.
Yeah, I heard that you are retired. Where are you now?
I have joined the Epic Hospital.
Epic Hospital. That's great. That's
Yeah.
great.
I do OPD there, but otherwise operate everywhere, wherever it is like that.
Okay. तो बहुत अच्छा. Epic join कर लिया. Epic तो वही है ना अनिल जैन, Dr.
Anil
Anil
Jain,
Jain.
Rajpat Rangoli Road.
हाँ.
We'll be starting DNB in this year or next year, depends. General surgery.
Okay.
That's
So
what
how
we are.
many consultants are there in Epic general surgery में?
4.
4 consultant. कौन है?
I have joined with my team Ankur Patel and Prujal Parekh.
Okay.
And there is a one Vivek Tank, he is also there. Dr. Bharat Shah is also there. So there are actually 5 of us.
5 of you. That's great.
So all the best for the new endeavor and many congratulations.
Thank you. I think you also left the.
Yeah, a couple of years back now.
Yes. I think when you came last for a workshop, you were with JJ, I think. Yeah.
So the last we met in Goa, I had left by that time.
Okay. I think you are with J&J.
Yeah, that and a few other places and around.
Yeah.
How are you finding the transition?
Excellent. Enjoying. You can say my workload is half now. But still continuing with all this because that's my passion.
Yeah, it's in corporate sector, it's really relaxing job. You don't have to rush and you can plan your job. So I think post-retirement, this is best. I also enjoy Apollo.
Madam, just now I have come back from USA and UK meeting both of my daughters.
Okay. I also went to a family trip to Italy and Greece.
Yeah, great.
And came back 15 days ago only. So now we can enjoy the holidays. In government, there is a lot of pressure.
Sir, it's almost 9. If we want, we can start. Dr. Smruti from Mumbai. She is also joining us in a couple of minutes. But if we want, we can start because Dr. Ramanna is already there.
Yeah, we can start now.
Dr. Smruti is there. I can see her.
I have joined in, sir.
Oh, morning, ma'am. Sorry, I don't know why I am not able to see in my laptop.
But yes, I am seeing you. Yes. Okay. So, Apurva, introduce everybody and let us start. Please. Welcome all of you. Yes.
Good morning, everybody, and thank you again for sparing that Sunday morning with us for an academic session on incisional hernia. Today, we are lucky to have stalwarts with us. Dr. Ramanna is there, who has joined. I think, sir, you are in Australia. In spite of the time zone, he has agreed to join. He is a founder member of AWR, founder president member of the AWR Society. And sir is associated with medical college as a there also in Melbourne as well as in Ramanna Medical. In Chennai, correct, sir?
Yeah.
Ramakrishna. We have Dr. A.M. Harra, who was with a medical college, and sir, he is also an exclusive AWR surgeon. Working with, I think now he is working in a capacity with with Johnson & Johnson.
Yeah.
We have Dr. Achal MM, who is one of our ex-BJIs. She was the HOD and superintendent at Seal Hospital. At present, she is a professor at Apollo Hospitals, Gandhinagar. We have Dr. Smruti Getla ma'am. She is the HOD at Lokmanya Tilak.
Sir, excuse me, I'm at Cooper Hospital, sir.
Oh, sorry. Oh, sorry. My bad. My bad. Sorry. And of course, Dr. Pankaj Modi, sir, who was my teacher, my mentor, and even now taking a lot of interest. And because of him, we are continuing with this particular program. I am Dr. Apurva Shah, Professor of Surgery at BJ Medical College. Today, we have a case of incisional hernia. Are we ready? Please share the screen. So everybody has joined online.
Pujan, let's share the slide.
Make it full screen, beta. As Dr. Modi sir said, it will be like a postgraduate exam. But because it's on virtual field, we allow him to complete the history part first, then we discuss. And same with the investigation treatment part. Of course, anywhere in middle, if you find that something grossly misleading is going on, any of the experts or the teacher can stop him and correct him. Pujan, start.
You are muted. Pujan, you are muted. Unmute yourself. Yes, now it is okay. Yes, start.
Good morning, sir. Good morning, ma'am. Today I am presenting a case on incisional hernia. I am presenting a case of a 76-year-old Hindu housewife from Ahmedabad having chief complaint of painless swelling in abdomen for last 10 years. Patient was relatively asymptomatic before 10 years. Then she had swelling in midline abdomen scar after 2 years of surgery. Initially small in size and gradually increase in size to present size. Swelling becomes prominent on standing, coughing, and straining. Swelling reduces in size on lying down but does not disappear completely. Patient is known case of hypertension since last 3 months, for which she is currently taking medication. No history of vomiting, constipation, obstipation, urinary complaints, chronic cough. No history of ulceration on swelling. Patient had operated for exploratory laparotomy with cholecystectomy before 12 years in emergency. Post-operatively, patient had pus discharge from lower part of scar, for which patient had underwent dressing for last for 2 to 3 weeks.
What was the incision? Pujan, just one question.
Sir, patient was operated by upper midline incision.
Okay, fine.
There is no significant past history. Patient is having history of 3 normal vaginal deliveries, 45, 40, and 35 years back. Bowel and bladder habits are unaltered. No addiction and sleep is adequate. No significant family history. Sir, general examination. Sir,
So, Pujan, can we just take a pause
Wait,
now
wait.
and
What
have
about summary? Summary of history.
Sir, 76-year-old female patient operated for exploratory laparotomy with cholecystectomy before 12 years in emergency. Patient had a complaint of swelling in midline abdominal scar since.
No. I am asking you summary. You are repeating the same thing. I am asking you summary of your history. I am not asking you to repeat. You are not written.
Yes, sorry,
Okay.
sir.
You are saying something.
Yeah. So, Pooja, little bit of housekeeping. Whenever you're sharing history from the patient,
Yes.
I think there are a couple of choices you have that are available to you. You could go with the symptoms part and then give the relevant history for surgery. But in cases like this, where the initial surgery is one of the main factors, I would rather somebody just start, with the general chronology that is there. When you share the surgical history, you can't use words like cholecystectomy. Like maybe if I come in as an examiner, I will not bother too much. But I know there are a lot of people out there who dislike medical surgical terminology being a part of the history itself. So you would rather just say gallbladder removal. And another thing that comes to mind is the symptom complexes. So now there are a couple of symptom complexes that you've not elaborated upon. One is, were there any complications after the gallbladder surgery? So all of the biliary work that we normally sit and talk about, negative history of jaundice, repeat interventions, things of that sort. And from an incisional hernia point of view, is she having any
बीमार हुआ
adhesive
बुखार आ गया
problem?
ना वो
There's somebody whose phone is not on mute. Anyways, so in terms of sudden distension, vomiting, discomfort, what the pain is the pain being exacerbated on movements? Did she have drains at the previous surgery? Is she having any discomfort there? Like all of these things should be coming within the history itself.
Yes, yes.
I would add a couple of points here. Because you're talking about a 76-year-old lady who presents to you with what is an incisional hernia for the, from the looks of it.
Yes, sir.
And you have started off by saying that the patient doesn't have pain. It is important for you at this point to outline two things. I mean, make this a part of your thinking process. I mean, everything here, I would say, should be very natural for you to think as a surgeon. When you're taking a history and the patient's telling you all this, at the same time, go on the side of the conversation and also find out two things. One is, what are her major comorbidities? Does she have a history of, say, PTCAs or bypass surgery or strokes or renal failure or anything like that? Those are very, very important. Whether she's on any blood thinners, whether she's got COPD or anything like that. That is one part. I'm sure you would cover it in all patients. But in this particular instance, when you're talking about incisional hernias and the patient starts off by saying, no, I don't have any pain, it's important for you now to ask pointed questions to the patient about her level of functional performance. Can she walk to the market, or can she walk around at home without any support? Can she go to the toilet? Does she need help? Why this becomes important is that when you're operating on an incisional hernia, which is non-emergent, quality of life is essentially what you are looking to improve. You're not saving the patient's life, you're not saving the patient's bowel, but you are basically improving the quality of life when you want to repair a hernia. So if you do not ask, what is her current quality of life, what are you going to improve upon? So this would be an important consideration if the patient were, say, 140 kilos and the patient smokes and drinks all day and just eats chips watching TV. There's no need for you to do surgery. You can just leave the patient alone. Because when you do a surgery in such a patient, that patient is surely not going to justify the risks that you will be taking and the whole team will be taking on behalf of that patient. Sorry, I took too long.
I think point well taken. So basically, Poojan, the idea is that why did she come after 10 years or 8 years? Is it the worsening of her activities, or or is it the thinning of the abdominal wall, or what? Achala ma'am?
Yes, I think a very relevant point to know why she is going to get operated, or why she has come for hospital for the treatment after so many years. She had swelling since last 10 years.
Uh,
And her age is 76 years.
yes, ma'am.
Okay. Okay, Poojan, so you have to elaborate on this.
Yes, ma'am. Ma'am, according to patient that in recent times she had difficulty in doing normal activity, so that's why they presented now.
Right, right. So what Dr. Amanna said is absolutely right, that she had her daily routine was in a problem, right, in the jeopardy.
Yes.
Right.
And
Uh,
does she have any precipitating factors? like cough, constipation, difficulty in micturition, something like that?
No, ma'am.
Because these are very important factors which can increase or precipitate your hernia in the body.
Was she lifting any weights? Because that part you have not said. Almost you have covered everything, but whether what does she do for living?
Sir, she is a housewife.
Okay. Okay. Pankaj bhai, Dr. Getla.
Yeah, so like Dr. Ramanna mentioned earlier that quality of life is important. If it was a laborer who was doing daily work and he required to lift up heavy weights, then of course our management would be different. But I think he's made it very clear that she's 76 years old, the housewife. Assuming she's a lifestyle, I would think in terms of management and how to go about it more different. So I'm okay with this symptom complex.
Pooja, next slide, please.
Yes, sir.
Why did you ask no history of ulceration on swelling?
Sir, as swelling was present since last 10 years, sir, there can be there can be possibility of any friction ulcer present. So, sir,
What is significance of that?
sir, if friction ulcer is present, then it is a complex incisional hernia. So that will affect our plan of management.
What is a complex incisional hernia? What may be complex for you may be bread and butter for somebody else. So unless you're giving us a classification system, stay very far away from these words.
There is nothing like complex actually.
So you can just say long-standing incisional hernia, higher risk of SSI, could be a sign of impending rupture, long-standing nature, but don't use words like complex to describe it. Layman's terms will get ripped apart by, you just need to give examiners a little bit of a deal,
Just,
So be a little careful regarding that.
Yes,
just for your information, Poojan,
Yes, sir.
if you by chance have a slip of tongue and you use the word complex incisional hernia and somebody asks you what is complex, remember it very, very simply. If the defect width of the hernia is more than 10 centimeters, it is complex. If the defect is close to a bony prominence, could be ribs, could be the iliac bone, could be the pubic symphysis, anywhere close to a bone, it is complex. If it is associated with a stoma, it is complex. If it is associated with any contamination, it is complex. Okay?
Yes, sir.
So, Poojan, my question still stands. Why you isolated and specifically ask about ulceration? We are talking of history.
Yes, sir.
So, why specified ulceration? What is the mechanism behind that ulceration?
Sir,
Where is the
because
incisional hernia situated?
sir, in epigastric and
Above
supraumbilical.
umbilicus, I think.
Yes, sir.
Here, right? So,
Yes,
which friction causes ulceration?
sir. Due to pressure necrosis, if patient has a
Is
history of
the hernia reducible?
sir, it is partially reducible.
Have you written that? Or patient doesn't mention that?
Sir, I have written that swelling is reduces on line note but does not disappear completely.
Does not disappear completely. So, how will it cause ulceration? So, remember, if it is, I would suggest, fine, you have written nothing wrong with it. But if you have written, you should be ready to answer it. Most of the time, if ulceration history is not that, don't mention it. Suppose patient had ulcer and there may be a scar. Then you mention it. Patient had ulceration and now there is a scar formation. Do you understand?
Yes, sir.
So if it is present, then mention it. If it is not present, just leave it. Because patient is not going to tell you that I did not have ulceration. That's what you are implying, that patient has told you that there is no ulceration in past. This is not examination. Do you understand? If
Yes.
patient is not going to tell you that, oh, I did not have ulcer.
Yes, sir.
So no need to mention that. That was I wanted to aim, because otherwise it can be in trouble. So why did you specify ulceration? Then why not about visible peristalsis? Those are more of an examination point. Remember that,
Yes, sir.
right? So
Yes.
patient had hypertension is 3 months only at the age
Yes,
of
sir.
20. That is
Yes,
real,
sir.
real surprising. Okay. Yes, sir. Anybody would like to ask, or we should move to examination? Apurva?
Yes, sir. Yes, sir.
Okay. Yes.
Yes, we can go for examination now. I
Right.
think any discussion on history.
Then if you have any clinical pictures, just show us the picture and then you start the examination part.
Yes, sir.
Okay, start with the examination part.
Yes, sir. Sir, general examination. I have examined patient with informed consent, inadequate light and exposure, with presence of female staff nurse. Patient is well built and obese. Patient's height is 160 centimeter, weight is 80 kilogram, and BMI is 31.25 kilogram per meter square. Temperature is normal. Pulse is 80 per minute in right radial artery. Blood pressure is 140 by 80 millimeter of mercury in right brachial artery in supine position. Respiratory rate is 18 per minute. No pallor, clubbing, edema over feet, or lymphadenopathy. Karnofsky score is 80. Inspection. I have examined patient in both standing and supine position. Single large swelling in epigastric umbilical region, approximately 25 into 25 centimeter in size, present. Umbilicus is transversely stretched and displaced downwards. Swelling is partially reducible on lying down but does not disappear completely. Cuff impulse test is positive. Upper midline vertical scar of previous surgery seen. Scar of drain site seen in right lumbar region. On straight leg raising, swelling becomes prominent. Swelling becomes prominent on standing and on raising head. Rest all hernial sites normal. No dilated veins present over swelling. No visible peristalsis. No ulcer, skin pigmentation, or sinus seen. Palpation. Temperature is normal and no tenderness. A single soft swelling palpable in epigastric and umbilical region measuring 25 centimeter in length and 30 centimeter in width. On lying down, it is reducing partially on its own. Defect is not palpable. On straight leg raising test, it becomes prominent, but defect size cannot be assessed. Expansile cuff impulse present. It becomes prominent on standing. Upper midline vertical scar measures 15 centimeter in size. No palpable organomegaly. Percussion. Tympanic note is present. Auscultation. Normal peristalsis present. Per rectal and back examination is normal. Respiratory and cardiovascular system examination is normal. Summary. Sir, 76-year-old hypertensive female is having 25 into 30 centimeter size swelling in upper midline incision on abdomen following exploratory laparotomy 12 years ago, and is having expansile cuff impulse, and it is partially reducible on change of posture.
Go back to your swellings, Pujan.
Yes.
So, palpation, your summary of
First, inspection, yes.
palpation.
Palpation, fine.
Yes.
So I'm not very convinced that you can talk about a soft swelling that is palpable, but what you can actually feel is a defect in the anterior abdominal wall, through which intra-abdominal contents are protruding out. You can feel it. Because by and large, you will not be able to palpate some swelling unless you're keeping the patient, constantly with the head raised kind of position. The swell, you can what one feels the defect and not really the swelling comes out and goes. So that would be my take on that. When you talk about the palpatory finding, I'm not very sure the others agree. Or...
Go to inspection.
Yes.
What is the height of patient?
Sir, height is 160 centimeter.
Right. So what is the normal length between xiphisternum to pubic symphysis? Normal length in a 160 centimeter patient. Why the meshes are coming in 30 by 30 size? Another word, have you measured actually the size?
Uh,
Have you measured the size of this swelling?
yes, sir. I have measured the size of this swelling, sir.
So is it a 30 centimeter, 25 by 30 centimeter? Up
Yes,
to
sir.
which level the lower border of swelling? You have mentioned that?
Sir, up
You have
to
written that swelling, each umbilicus is transversely stretched and displaced downward.
yes, sir.
So it is up to umbilicus,
Yes, sir. Up to 3 centimeter above, up to 1 to 2 centimeter above umbilicus.
above umbilicus, and it is 25 centimeter.
Yes, sir.
Okay. Right. On inspection, how did you say it is partially reducible?
Sir, because all the contents were not reducing fully, sir.
Hey, that is a theory. How did you say? Show me the picture. So in the first picture, how did you say that it is partially reducible?
Uh, Sir, because there is a bulge seen in epigastric region, sir.
Right. So is it on inspection? Can you say that it is partially? Just I'm asking you, how did you say that on inspection? How can you say that it is partially reduced? The size is so large, right?
Yes.
We will come to that, sir will ask you, but except the hernia is so large that reducibility does is matter. Anyway, just think it over. Go back to inspection. Sir, would you like to ask anybody? Like,
Ahem. Dr. Ramanna, yes, sir.
I basically think one of the more impressive comments during your presentation when you're talking about inspection would be also to mention what is the nature of the scar that you're seeing.
exactly.
Is it a linear, well-healed scar, or does it show areas of ragged, wide, thinly atrophic scar, which signifies that, you hinted at it, that the patient underwent an emergency cholecystectomy and probably had a burst abdomen or wound infection or some sort, and the scar would testify to that. Why this is important clinically is that when you're doing the operation, assuming you're operating on this patient, you would need to excise that scar and give a nice linear scar to the patient. So this would be part of your calculation as a surgeon when you're handling a patient.
Yes, sir.
Ahem.
No, so pretty much the same. Would have liked some comment about hypertrophic scar, keloid, how stretched it is. The nature of the sutures also becomes very apparent. In the first image that you showed, I was actually wondering if the patient had undergone tension band suturing. They were that widely spaced, but I think in the other ones it just became easy to see they were interrupted sutures just stretched out.
Also, we can make out, I think we are quite understand why he used the word complex beginning.
Yeah.
So,
It does look like a complex hernia.
Just for the sake of exam point of Pujan,
Yes.
what is cough impulse taste?
Sir,
It is cough impulse is positive. There is nothing like a taste. Okay, when you speak, you may not speak, but don't say it is a taste. It's a cough impulse.
yes, sir.
Would you like to add anything in this, in cough impulse? Which type of cough impulse it is?
Uh, Expansile cuff impulse, sir, present.
Sorry, I didn't get you.
Sir, expansile cuff impulse is
What is
present.
that?
Sir, Sir, when the swelling becomes more prominent and spreads in all direction on cuffing, sir.
Right. So there is an expansile cuff impulse is present. Right?
Yes,
What
yes,
does it signify?
sir. It signifies that the sac is spilling over from the defect laterally in all directions.
Not necessary. Not necessary. Even if it doesn't spill over, expansile impulse may be present. It suggests this is just for a postgraduate exam point. It doesn't make much significant. But if some examiner may ask you, sir, there is an actual increase in a content of the hernia.
Yes,
That
sir.
suggests that there is which each cuff impulse new contents are coming, and it suggests it's not completely irreducible. When it becomes completely irreducible, there may not be cuff impulse present, but it's not a test. Remember, it's a natural part of your examination. What did you see in a standing position? You examine in standing posture. What did you see in a standing position?
Sir, I first examined for whether the swelling is becoming prominent or not.
It is a prominent, partially reducible. Anyway, it is prominent. So we have made it a habit. We always say in standing and lying down position. But what do you see specifically in a standing position? And why did you examine this patient in standing position also? Do you understand my question?
Yes, sir.
So you have to justify yourself. You have examined the patient in standing position.
Sir, sir, so that I can have a specific idea about the extent of the swelling.
So why do you examine in standing position? What extra thing you get? There will be more of an increased intra-abdominal pressure, which will make the hernia more prominent, and you can judge it. And by looking tangentially also, you can have a rough idea about the size of hernia. But remember, the usually standing position is useful for a small hernia, specifically inguinal hernia, which may not appear, particularly indirect hernia, which may not appear on lying down or even on cuffing, and may appear on standing and walking only. So that's why that is a significant. We make the patient stand to increase intra-abdominal pressure. In a such a large hernia, it is not going to make much of a difference.
Yes, sir.
Okay.
Madam,
Yes,
One
somebody.
more thing, Poojan, in the abdominal examination, you have not mentioned about the intra-abdominal organs. You should mention about any other swelling in the abdomen, condition of the liver, spleen, etc. You have mentioned only the wall, not the intra-abdominal contents.
And also some amount of touching upon how do you think the musculature is. Yeah, when sir was asking you about standing, it also gives you an idea about the body habitus and the fact that the patient, what kind of, like it was mentioned earlier, the quality of life, whether it's muscular, not muscular, very lax abdominal walls. Because in your mind, you're going to think about how you're going to manage it later, whether it requires that kind of rigorous management where you want to take care of the cage, the abdominal cage and get back, or you can just get by with, she's 76 years old, so you can get by with a lesser procedure. So it kind of gives you an idea when patient is standing, when you examine the muscle tone, whether what are you going to do with the patient eventually.
and I think with being the incisional hernia case, the size of the swelling is not important. See, at the end, you have written size of the swelling. I think what is more important is whether you are able to palpate the transversus abdominis or not. Were you able to palpate the muscles, rectus?
Sir, no, sir. Sir, because it was, sir, only partially reducible, sir. I was not able to palpate the
But
muscle.
partially reducible meaning you are not able to get inside. But I think laterally, see, the muscle are going to be on the lateral aspect of the swelling. And
Yes.
that is actually very important when it comes to a case of incisional hernia.
What about abdominal tone? Have you mentioned anything about that?
No, sir.
This is one of the important. I will be telling more about it, sir. Because that is the important point. That will help the standing. One more idea is that Malgen's bulging, lateral weakness, which can be assessed. This hernia may be large, but in most of the cases, you are able to. Yes, Aham, you were saying.
So in female patients, particularly who've had multiple children, or in male patients that have poor tone, classically when they stand up, irrespective of what hernia they're having, you'll see a teardrop abdomen, where the lower abdomen just kind of bulges out a little bit. Now, this is all very subjective. I think in your case, what is complicating the matter is just the sheer size of the defect and the volume of the hernia itself, and also the patient's obesity, where you may not be able to appreciate it. But in a lean patient, particularly in men, I think that becomes a very relevant point for discussion. Something else that you can maybe appreciate in these patients is when you make them do a head raising or leg raising, you're able to, even if you're not able to get to the defect, you may be able to appreciate some diastasis directly on top of the hernia or below the hernia. That's another watch out. Now, of course, whether there is a diastasis or no will be finally given to us on a CT scan. But this is one decent little thing that we can do during clinical examination just to figure out what the stretch is going to be like. You see, the defect will more likely be circular, but there's usually a triangular area of weakness and a triangular area of weakness like above and below. And that also needs to be repaired at the time of surgery. So it's a lot of crazy tightening that has to be done. So that would be one bit. I'll walk away from the hernia a little bit and just ask you another straight up question. Of all the systemic examination that you would perform in this patient, what would be, apart from the abdomen, the one place that you would have maximum concerns?
Yes. Sir, apart from abdomen, I will have maximum concern for respiratory examination.
All right. Could you share why?
Sir, as due to a large incisional hernia, sir, post our operative management, there can be respiratory complication, sir, due to sir, maybe due to sir, abdominal compartment syndrome, sir. So that's why I will like to examine respiratory examination after abdomen examination.
See, again, now this is how you set yourself up for success. A little tip from my side. If you start with abdominal compartment syndrome, I will ask you what is the classification of ACS, what's abdominal hypertension. Then I'm going to ask you the pressures. Then I'll ask you how you do bedside measurement of pressures. Don't go down that rabbit hole.
Yes, yes.
First, in patients with large incisional hernias, these are the basic derangements in their physiology that are expected. So now, can you summarize what happens to a patient's respiratory system when they have large hernias?
Sir, because sir, when they have large hernia, the diaphragm is pulled up towards thoracic cavity. Sir, they'll tend to have tachypnea and shallow breathing.
Oh, like you need to be a little more specific. There's other problems. Okay, so what are the primary muscles of expiration?
Sir, diaphragm, sir.
वो inspiration का है भाई, expiration का नहीं है. Diaphragm contracts, we inspire.
Uh, sir,
Forced expiration. Let me put it in those terms. They're the abdominal muscles, no?
yes, sir.
So see what's happening. I'll move it along just in the interest of time. When you have a disconnection of the linea alba or any other part in the abdomen, what is landing up happening is that cylinder of the abdomen with diaphragm on top, pelvis below, and the abdominal muscles all around it, that gets disrupted. As a result of it, just like when you have multiple rib fractures, what do you get in the ribs? Favorite question, Sabka? You get
Sorry, sir, I don't get it, sir.
when you have multiple rib fractures,
Yes,
we say the patient has so and so movement at the chest.
yes, sir. Paradoxical movement, sir.
So now, when you have a large hernia, you land up getting paradoxical motion even at the abdominal wall. Your forced expiration is also worsened. Your inspiratory capacity is worsened as a result of all of this. Then you, after you finished off with this biophysiology, then you go into whatever else, I'm now worried about the patient's current respiratory reserve. And these are the things that I would like to do to ensure that she has a good post-operative course. Don't directly dive into abdominal compartment syndrome. First, physiology, pathology, and then complications. That's how I would take it.
Also, abdominal compartment syndrome is not linked to respiratory compromise. Abdominal compartment syndrome is abdominal. The extra abdominal aspects are different. So one doesn't have anything to do with the other necessarily. You know what I'm trying to say? Your respiratory compromise is respiratory compromise, where your muscles are weak and they're not able to expand well, not trained well. The patient has very low functional capacities, respiratory capacities. So those things are not necessarily linked to abdominal compartment syndrome. They could be linked to abdominal hypertension, but ACS is a different disease.
In itself.
Yes, sir.
So, Poojan, I just want to call out one thing is that an incisional hernia is actually a very challenging case for an MS exam. I'll tell you why. There aren't that many examination findings or relevant things in history, apart from if you have a crazy surgical history and a lot of things have been done, then stuff gets interesting. But in your case, it's a fairly straightforward expiratory laparotomy. There's nothing positive. It's a long-standing hernia. Luckily, she doesn't have any complications and all this stuff. So, अभी problem होती है ना कि the marks you get are a direct reflection of how much you're able to talk in the exam.
Yes,
And
sir.
the way that most MS and DNB exams are structured is that a lot of the discussion is actually supposed to happen on history and examination findings. And it's when you get into the treatment phase where you're like, okay, I'm beyond a certain threshold and now the viva is going pretty well. Now, what happens in an incisional hernia is there's not a lot to talk about in history and this. So you directly start going into the textbook knowledge. We directly start going into the treatment phase. So you need to be very well prepared on that front as to what the expectations are. And the thing can go in a lot of different directions. I can share. So I had incisional hernia in my MBBS exam, and Dr. Ghetla was actually my examiner that year. So little trivia that I can share over here. And I can tell you it's a challenging bit. It's challenging for MBBS. It's challenging at an MS level also because it shoots in several different directions. There's a lot of concepts, classification systems. So you need to move across very, very quickly and not get stuck in history and examination findings in this. And just go on to your plan of action. Just keep that in mind when you plan to presenting this.
So
Yes,
thanks for throwing my. Thank you very much for throwing my age. But I was 20 years ago. The concept of AWR was not there at all. We were just doing some of us were doing some inlay maybe. I'm being very frank about it. We had so many apartment syndromes. So, like you said, everything is changed. The paradigm shift is the last 5 to 10 years. And we are also talking more about it in 10 years. That he needs to know more about it. We are getting stuck long for half. At all these other things, when we go and talk about what do you have, how can we bridge the difference what is there. So we are not reaching there at all, Poojan. We go there. Yeah.
But I think you should throw some light on what we have discussed regarding the abdominal compartment syndrome, because in exams and because it's a masterclass, I think we should discuss it. So you can try to elaborate. You already have experts if you have any issues.
Sorry, sir.
What do you mean by abdominal compartment syndrome, and how do you measure the intra-abdominal pressure?
Sir, abdominal compartment syndrome is defined as when intra-abdominal pressure is increased from its normal limit, which is 8 to 12 millimeter of mercury. Sir, and when it becomes more than 15, more than 15, sir, it is called as abdominal compartment syndrome, leading to respiratory distress and cardiovascular distress also. Sir, we measure intra-abdominal pressure with the help of periurethral catheterization. Sir, we join the intravenous set to the periurethral catheter, and we inject approximately, and we keep that at heart level, and we inject 20 to 25 ml of normal saline into the periurethral catheterization, and then I will check for the column in the intravenous set, and will measure it and via measure tab, and that will be, sir, centimeter H2O of intra-abdominal pressure. Then, sir, I will convert it to millimeter of mercury.
Any expert comments? Dr. Ramanna, sir.
So abdominal compartment syndrome has a very specific definition. I will just keep it simple. So you've correctly mentioned the normal range of intra-abdominal pressure, and that it exceeds 15, then it is considered as intra-abdominal hypertension, right?
Yes.
When intra-abdominal hypertension is associated with organ dysfunction or worsening of organ function, it is known as abdominal compartment syndrome. So it does not mean that you should have a full-fledged renal failure or liver failure or bowel ischemia to happen. You can actually have, say, an increase in the level of creatinine. If the patient's creatinine was, say, 1.6 initially, and now after your operation, your intra-abdominal pressure is 18 and your creatinine is now 2.1, this is ACS, right? So
Yes.
worsening of organ function associated with raised abdominal pressures. And you've mentioned that we measure it using a manometer connected to the intravesical, to the Foley catheter and all that. It is commonly used, but still is not a perfect measure, right? We should keep that in mind. It is not a perfect measure, the intravesical pressure. So it still would be a clinical diagnosis. And one of the most important things after you do an incisional hernia surgery and the patient is suspected of having abdominal compartment syndrome, one of the most important things is when you have hypotension, oliguria in a patient who has a tight cylindrical abdomen, right? So this still remains the hallmark of a clinical diagnosis of ACS. And if you do a blood gas, you will see that there is a metabolic acidosis which is happening. So the important thing is to detect it as soon as you can and start aggressively treating it. Otherwise, irreversible organ dysfunction can happen. And if that happens, the patient will die. Okay.
Yes.
Very, very high chance of death if there is irreversible organ damage.
Yes, sir.
PRM, sir. Achale, ma'am.
What about the other systemic examination? Any other comorbidities, etc., in the examination?
I think he has written last. Before somebody go to that slide, Pujan.
Yes, sir.
Okay, fine.
Pujan, you mentioned BMI is 31, I believe.
Yes, ma'am.
That get your antenna up in any way, or would that kind of make you think about now what next, or are you scared, or would you seek help because 31 BMI is acceptable in an Indian population?
No, ma'am. It is obesity, class 1 obesity.
Will that change your management way?
Yes, ma'am. It will. Yes, ma'am. Obesity will. Sir, obesity is also a modifiable risk factor for a recurrence after incision hernia repair. So, first of all, I will advise patient to lose weight and reduce the BMI preoperatively.
How long can you wait to reduce weight? Can you just send the patient away, come back after 5 years, or come back in 6 months? How long would one want to wait? Are you scared of losing the patient to some other surgeon?
This is difficult question, Pujan.
Difficult question. It is difficult.
There is actually no answer to it, to be frank. But what will you say?
Sir,
A healthy trial once. You can try and see a trend if possible. There has to be an effort on the patient's part. You can't do an abdominal wall repair with a BMI of 31 and the patient is going to be comfortable and not have recurrence. It is highly improbable to not have any recurrence, no matter what you're going to be offering or doing in terms of surgical.
So, Poojan, just one more point. You said that obesity is a modifiable risk factor for recurrence, but I think what ma'am was referring to was the current index surgery, right? There's a lot of stuff in the preparatory optimization phase and what can happen in the peri-op period. So don't just directly jump to recurrence. So as ma'am said, that it is not acceptable. You want a little bit of commitment from the patient side also. When you're undergoing such a massive procedure, you're going to be putting in a lot of effort. It's a high stakes situation, especially given the age of the patient. So what actionable advice will you give the patient for losing weight?
Uh, sir, uh, sir, I will advise patient to to take low carbohydrate and high protein diet, and also to do regular exercise.
What exercise? Is she doing ab crunches? Is she doing deadlifts? See
No,
that. So tell me actionable advice that you would give to a 76-year-old.
sir, I will advise for sir. Sir, I will give first di di dietary advice, sir. First,
Okay.
The most important giver is to be a little more mobile, start walking, because walking will improve her lung capacity. It will improve her abdominal, tone, her musculature, and maybe at the end of 3 months, if you see some actionable weight or some measurable weight loss, you can think you're on the right track, and you can think of planning surgery. But after doing all this diet, low carbs, high whatever, high protein, I don't think a 70-year-old Gujarati female in Ahmedabad is going to be having high protein, low carbohydrates. I have doubts about that. But like I said, walking is a better exercise. You can make them walk. It increases the lung capacity. It increases musculature. And that will give you some amount of an idea about how the patient is going to do post-operatively. Otherwise, it's going to be a no. We are going to be in a mess otherwise. If you operate on the patient right now, she's a complex abdominal hernia in your words. And
If I may add a couple of points, I don't mean this to be part of a cross-examination in any way at all. Just sharing some
Please.
perspective, which is that in this kind of case which is being presented, I would say that for me, a BMI 31 is not a hurdle to fixing the patient. My primary focus is, number one, whether the patient actually needs surgery. Number two, whether the patient is in a good enough physiological and functional reserve for the surgery to give her the best outcome. And three, whether this surgery is something which will potentially give advantages to her lifestyle at all, as I said earlier. So these are the important things that will come into the calculation, whether we need to operate on this patient or not. Not per se the BMI under 35. It's, let's say that the evidence is that the outcomes are good. Above 35 is problematic. The higher the BMI goes, the greater the chance of surgical site infections and other complications. Now, the other thing that I was thinking about, we were talking about exercise and all of that. Now, the most fundamental thing about exercise includes one fact, that it does not help in weight. What helps in weight loss today is caloric restriction, which means diet, and you all know the problems with that. But today, you have to mention pharmacotherapy. You have to use the GLP-1 agonists where the patient is a candidate for them, because in the short term, I have no disagreement with trying to make this patient lose weight. I wouldn't put it as a barrier if she were symptomatic. So you must find out whether this patient can be put on a GLP-1 analog to help her lose weight, potentially. Obviously, the economics, etc., are all going to skew the calculation. But I would say, practically speaking, diet is hard to follow. GLP-1 analogs make the results astonishingly good and in a very short time and lead to potentially good outcomes. And the emerging trend across the world is to use GLP-1 analogs. So exercise is good because it helps to increase the bone density and the muscle mass. So one of the things which is going to impact on outcomes in an elderly patient with a complex hernia, large hernia like this, is sarcopenia and frailty. These are the two most important ancillary factors in the patient, which you should keep in mind. Is this patient frail? Does this patient have the ability to withstand a major operation that I do? This is what will ultimately lead to the patient dying or thriving after your operation. Again, sorry, my comments are very long. This is one of my favorite subjects. I should keep quiet.
Sir, why you should keep quiet? This is what we are here for. Everybody has a time and place. Great. So that in continuation of that, I would like to ask the panel a question. So in today's this is a very popular among the bariatric surgery. Offer the bariatric surgery followed by hernia surgery in a very high BMI. Sir, because
Absolutely.
in a last exam, one examiner asked this question. That's why I've raised this. Yes.
Yes. So not for this patient, number
Not for
one.
definitely not for this patient.
Suppose this patient had a symptomatic hernia and it's a large symptomatic hernia. BMI is, say, 42. Would we offer bariatric surgery? Theoretically, yes. In practice, how are you going to do a laparoscopic sleeve gastrectomy or a gastric bypass where the upper abdomen has all the bowel under the skin and the muscles are way towards the side? It is not impossible. It is definitely possible, but offers a significant technical challenge even when the patient and surgeon both agree that they want to go for bariatric surgery first. The other thing that if you subject a symptomatic patient to weight loss surgery first, there is at least a 30% chance that the patient will come to the emergency with an obstruction or strangulation well before the. So weight loss before abdominal wall reconstruction is an ideal qualification or requirement. But in practice, it does not happen in at least 1/3 of patients who agree to it. Most of the patients will say no to bariatric surgery. Most of the surgeons will say no to bariatric surgery. But among those who do agree, 1/3 will actually end up as an emergency case with worse outcomes. Therefore, it is not a very black and white situation that if you do bariatric surgery in a fat patient with a large hernia, the outcomes will be good. It's not necessarily so. It's a mixed story.
Yes, yes. So that's the point. Not much because the most of the time this hernia is so large, to entry will be difficult, to perform the surgery will be difficult, and post-operatively patient will not have a good outcome. So most of the time it is no. That's what general. I am saying generalization.
But we still have other options that
Yes.
include the use of a dietitian and a therapist and an exercise trainer, a psychologist, and the use of bariatric endoscopy, like a gastric balloon. But today, GLP-1 are absolutely mainstream now in managing an obese patient who needs multidisciplinary management is GLP-1 analogs. No
Yeah.
question.
Yes. And the pharmacotherapy has also come long way. Nowadays, there are options available which can help the patient with obviously risk of complication in that. That's fine.
So, Poojan, if you by chance get a bariatric surgeon as your examiner who gets very offended by pharmacotherapy and says, Nee, I want to do surgery only, you will answer a sleeve gastrectomy if the hernia is low enough. So, you put very high cranial ports and a sleeve gastrectomy because you don't have to do any complex anastomosis. It's a relatively simple, straightforward procedure. It's just to get their weight down enough. From a surgical side, that becomes a procedure, the surgery of choice. From a bariatric procedure side, what Dr. Amanna just mentioned, a balloon or an endoscopic sleeve gastroplasty makes a lot of sense. But as almost everyone on the panel is agreeing with this, is pharmacotherapy is here to stay. So that I think more and more will end up becoming the standard course of action for these patients. I also want to point out a little empathy that I have developed for these patients after one episode. I had a loss-of-domain parastomal hernia in a patient that had undergone a lap APR some time back. And her BMI was 38, 39, and she just could not drop weight. So I tried for 3 months, 4 months, 5 months, and then she just kept complaining of pain and nothing was moving. So I said, "Okay, chalo, I'll take you up for surgery." When she came back for her 6-month follow-up, she dropped a significant amount of weight. Like I'm talking about 10, 15 kgs at one shot. It was visible when she walked in. And I got scared because I thought she may have had a recurrence or some residual tumor that got missed in the CT. But she said, "Doc, last time, आप कह रहे थे कि walk करो, but दर्द इतना हो रहा था मैं कर नहीं पा रही थी. And after surgery, now I'm able to walk, so I've lost weight." So the hernia in itself could be a confounding variable, which is limiting somebody's physical activities. So that lever may not be a viable option for some people, as has been discussed. A lot of these patients end up feeling a lot better after the surgery. They are able to subject themselves to a lot more physical activity, are more mobile as a result of it. I've had grandparents who say they can now lift up their grandchildren after surgery. It's having less discomfort things. So that sort do happen. So just keep that also in mind when you're formulating your answers.
Yes, sir.
Okay, sir, madam.
I think we should
And-
get the fact that
yes.
he wants to invest.
We can go to investigation and management.
What he wants to investigate, what he's having.
Sorry, madam, sorry, one of you, please.
Yes, Dr.
Smriti madam, please.
So we need to go ahead in terms of investigations and investigations in terms of what you have in mind for managing a large hernia which is 25 centimeters in length.
That is coming up, ma'am. That is coming up. For
No.
sure. Ma'am, Acharya ma'am, you are saying something?
Same thing. Now we should proceed to the investigation and management.
Yes.
Okay, Pujan, what investigation you will do? How will you manage this patient in general? Everybody wants to know.
Sir, first of all, sir, I want to get patients complete blood count, serum protein, albumin, and liver function test and a renal function test done, sir. Sir, after that, sir, I want to go for chest X-ray and erect abdominal X-ray. So then followed by sir ultrasonography, abdomen pelvis, and followed by sir contrast enhanced CT scan of abdomen pelvis.
Poojan, why a sonography? I'm not able to understand that if you're wanting to do a CT directly. Or can you tell me what are the advantages, disadvantages of the different imaging options in this particular case? Don't give me general stuff.
Sir, on the basis of complete blood count and serum protein albumin.
Just imaging. That is all preoperative workup. That's a standard general. That's a part of general surgical workup. Forget all of that. Tell me just imaging for ventral hernias.
Sir, I will like to get contrast and a CT scan done, sir.
But why X-ray and sonography?
That's what Pujan sir is giving you hint. He has specifically used words. So this point, all of the residents should keep in mind. Because examiner always give hint, but you are always obsessed that I am going to CT and discuss CT. Why not sonography? One more investigation before CT is a pulmonary function test in all such cases. Never forget them. Have you mentioned X-ray chest?
Yes, sir. I have mentioned.
X-ray chest. It is not a general investigation. It's a specific investigation for this case. Similarly, why not first sonography? Why straightway CT? So you will not do sonography in this patient. That's the sir is asking you.
Sir,
He had given you hint, but you did not take hint.
Sir, I will do ultrasonography abdomen pelvis in this patient first.
But then go to CT.
Sir, it will give us a primary idea about the content which are herniating out and whether there is any dilatation of.
I'm going to stop you. Do you have any doubt about what contents are herniating out at the end of inspection and examination?
No, sir.
So how is that going to impact your operative course? So asking very specific questions. So
Yes.
the diktat is not because the radiologists don't do CT scan before they do a sonography. That is not the logic over here. In an ideal situation, you have to do minimum to achieve maximum. And if you are not going to operate in the patient without information from a CT scan, then that becomes your primary investigation. Does that make sense? You don't want to jump through hoops. Like an abdominal X-ray is absolutely useless unless the patient is in acute obstruction at this point in time. Sonography becomes highly subjective, does not give you a defect width. Because think about it, the probe that you're holding is about this wide, right?
Yes.
Has a field of view that is just a few centimeters wide. How are they going to figure out a defect that is 20 centimeters wide? फिर वो radiologist सोचेगा पहले हाथ इधर था ये फिर हाथ इधर आ गया तो now this is approximately 15 centimeters across. So it's very subjective, open to interpretation. Interpretation does not give you accurate data. And there is nothing in this patient that a sonography will find out that a CT scan will not. You understand? It's a very clear-cut incisional hernia case. I could make arguments that you actually only need a plain scan in this patient because she doesn't have any prior history of malignancy. She does not have a prior history of hernia repair. She does not have a prior history of significant SSI that is recent. And at this point in time, she does not have any red flag signs saying that there is something festering under the skin. If you feel like the patient is having like say has a sinus, could be an intracutaneous fistula, there could be an SSI from a previous mesh, then all these things you need contrast CT. In 90% of the patients out there similar to this one, irrespective of the complexity, a plain scan does remarkably well. So that would be my argument. But you are not wrong to say that I want to have my bases covered and I want a contrast scan. But my point is go directly to CT scan and you will be justified in your exam to say that no, CT is the investigation of choice in this patient because it is not only helping me in diagnosis, it is characterizing the problem and it is going to give me objective parameters that help me figure out what to do with the hernia. Whether I should do surgery or no, whether any optimization is required beforehand. So now when you're looking at the CT scan report, what are the specific things that you are going to demand from your radiologist?
I think he has the plate. Please upload the plates.
Yes, sir.
Oh, he has a video only. This is a
I
luxury
was
in India as
asking
well.
Pujan, what will you see?
Yes.
Not what will you ask? This is an important question, I
Yes.
believe, because they
Yes,
are
sir.
very fond of type of CT and that. That's what. Yes.
Sir,
Continue, Pujan.
sir, I will ask for carbonyl index, Tanaka index, in this complex incisional hernia
Can you
patient.
pause this here? Just one moment.
Yes, sir.
Can you tell me what phase of CT scan this is?
Pause it.
इधर थोड़ा ऊपर जाओ, थोड़ा ऊपर. हाँ, ठीक है. Go ahead, go ahead, go ahead, go ahead. So is this a plain cut? Is it arterial, portal, or venous?
Sir, this is arterial phase.
Are you sure?
Yes, sir.
So go back up, please. Go a little up. You'll be able to see the portal vasculature and the hepatic veins in the liver. Go up, go up, go up, go up, go up. Cranial, cranial. Go up, go up, go up, go up. Okay, pause here. Can you see the hepatic veins?
Yes, sir.
Okay. In an arterial scan, you cannot see the hepatic veins. Light up. They're clearly having contrast inside them. So this is, if you're saying it is an arterial scan, it's not a well-timed arterial scan. So first things first, you should know what phase you're looking at. All right. So this is a portovenous phase. Depending on what time, I would assume this is more venous than portal, but that's up for interpretations. Yeah, please go ahead.
What type of CT and what are you looking at? Pujan, sir, पूछो तो PRM sir पूछो.
Yes, sir. Yes, sir. Sir, on the in the CT scan abdomen pelvis, sir, I will be looking at the size of defect, contents which contents are herniating out, and also rectus muscle status and external oblique, intra-oblique, and transverse abdominis muscles status, sir. And
What
also,
is
sir,
status mean? Single,
sir,
married, complicated?
sir, sorry, sir. Sir, I will be looking for the width of the muscle, sir.
Okay.
And sir, And sir, also whether there is any bowel dilatation present or not. I will want to check, sir. And I will ask for the certain index from radiologist, that is Tanaka index and carbonate index.
Looking at the CT scan, do you feel like the patient has loss of domain?
So what is the by definition, what is loss of domain? That will be the first question. Then you come on this.
Sir, loss of domain means any massive hernia which is protruding out of size of defect, and it will be difficult.
But definitions are not speculative; they are definitive.
Yes, sir. Sir, massive hernia which will have which cannot be reduced back inside the abdominal cavity, and
Ahem, please.
So, loss of domain as it stands right now means a long-standing hernia where most of the abdominal contents lie irreducibly within the hernia sac. I don't mean most actually. And as far as CT volumetry goes, it is somewhere between a minimum of 20 to 25%. There are different definitions that go about. In this particular patient, the reason why I asked is you can see that the defect is very wide, but most of the contents are actually below the level of the defect. Does that make sense? In standing, it becomes very dramatic. So you'll have a lot of patients who you examine in standing position, you feel, अरे huge hernia यार, ये तो बहुत problem होगा. But the moment they lie down, the abdomen becomes very accommodating. So they don't have true loss of domain. Everything returns back, which is also one of the reasons why we always do a standing and lying down examination in these patients, because just a standing posture can be very deceptive. What you would, rather than saying status, just say the thickness of the muscles, whether there is any denervation injury from the prior case. Now, she luckily has a midline incision. If she had undergone a subcostal incision, she would have denervation on that side. Okay.
yes.
So you would, so let me ask you, what is the implication of muscle denervation in your eventual surgery as far as things that you do and setting patient expectations? These two things, if you can answer.
Uh, Sorry, sir. Sir, I didn't get
So,
this.
say the patient has a subcostal incision. There is an element of muscle denervation. She's undergone standard subcostal cholecystectomy, has denervation. You can see it on CT. There is asymmetry. The muscle is very thinned out, both the rectus as well as the obliques.
Yes.
Now, how is it going to impact what you are doing at surgery? That's one. Two, what is a discussion that you have to the patient that is most relevant in this situation?
Sir, sir, if the muscle is if there is denervation and muscle are in less width, sir, intraoperatively, sir, there will be even after releasing those muscle, it will be difficult to close the defect, sir.
On the contrary, if it is a denervated muscle, it will be a lot easier to close because they'll be very stretchy and pliable. They don't have crazy tone. They balloon out very easily. So, first things first, when you have denervation injury, that's not typically a hernia problem. Denervation associated with a hernia. What you need to make clear to the patient is that you're not going to be able to cure the denervation and that dysfunction will remain even at the end of surgery, no matter what you do. So there will be some bulge, some dysfunction, some discomfort that they feel on and off over there. From your surgical decision-making side, if there is an opportunity to plicate set muscles to bring them tight together, that's one. You can do that in certain situations. Two, if in case you are giving an overlap under a denervation, you always prefer a heavier mesh that holds the muscle better as a result of the fibrosis that is less likely to bulge out. So that's the trade-off you'll end up doing. That denervation cases that we are likely to bridge recurrent cases, you'll end up using a heavier mesh in comparison. So just keep that in mind.
Yes.
Ravana sir.
I can't see him. I think he's dropped.
Does it matter whether the mesh is heavy or it's light? And any idea what these meshes terms mean in terms of lightweight or heavyweight?
Yes, ma'am. Ma'am, they are classified based on their gram per meter square. Sir, heavy weights, heavy mesh are have more chances of more chances of foreign body reaction and also contraction in compared to light mesh.
But what are the definitions? Ma'am asked, what's heavy, what's mid, what's light, what's very light?
So, I don't know, sir.
So there are two different definitions that exist. One is for ventral hernias and the other is for inguinals. But by and large, the one that we follow is this. A heavyweight mesh is anything beyond 90. Uh, say a midweight mesh is somewhere between 50 to 75. That's the average range that we'll end up having on meshes. These are industry meshes which are available right now. 35 to 50 would be classified as a lightweight mesh, and anything less than 35 is considered to be a very lightweight mesh. So this is on average the classification system that we follow. So heavy, always remember, is 90 and light is 35 to 50. 50 ke upar becomes midweight. Just keep that in mind.
And
These are only for polypropylene. This does not hold true for polyester. Yeah,
And
sorry.
also that, I'm sorry. So also that the heavy ones are used are smaller in size. They will not be very large ones. And we will use probably the lightweight ones or the so-called macroporous ones that are there for the large, larger size that's available. That's it. Where are you going to use a large one? It will be probably macroporous or light. Like inguinal, we'll use small ones, so it will be like us and a little heavy. You want more fiber quickly.
PRM, sir. Achale, ma'am.
In the inguinal hernia, if the muscle tone is not very bad, we can use the lightweight mesh, because the advantage of light mesh is the pore size is bigger and foreign body is less in weight. So foreign body, once the pore size is bigger, more fibrosis and granulation tissue, and the mesh is taken up very well. When muscle tone is not good, muscles are weak, or they are atrophied, or they are denervated, then we need a heavy mesh because it will give extra strength to the wall, abdominal wall. In this case, the muscle tone, particularly of the central muscle, it seems that they are muscle tone is not good, and it's more of divarication also. Along with the incisional hernia, both the recti, they are pulled laterally. So you have to give more strength to the central abdominal wall. So if you consider repairing it, I think the heavyweight mesh will be more appropriate.
Yes, ma'am.
PRM, sir.
What are the findings in your case? Of CT?
Yes, sir. Yes, sir. Sir, in contrast and a CT scan, so there is a 12 centimeter but 12 centimeter by 14 centimeter size defect in midline anterior abdominal wall. 12 centimeter in transverse diameter and 14 centimeter in length.
Pujan, why this much difference is there? That's why I raised that question in beginning. You were saying 25 by 30. What is the reason of difference?
Sir, as it is a long-standing hernia, the sac is spilled over laterally in all direction, and
Mushrooming, very simple answer. So what is significance of that? How does it affect your management?
sir, sir, I don't know, sir.
The point is that is the important point. Whenever there is a mushrooming, when you are operating such patient, it is very important to take care of this. So that's why asking hernia cannot be of 25 centimeter when it's covering half of the abdomen. Actual size will be quite less. So all the patients of hernia who has a very large mushrooming, the actual size of, and particularly when it is partially irreducible, and that is the one more important importance of CT. So actual size may be quite less compared to the what you have measured. And particularly when the hernia is reducible, the importance of tone and straight leg raising is there. In a patient of partially irreducible hernia, it is not of that significance. So keep that thing in mind. If somebody asks that it is very difficult, the answer of that question, sir, because there is a mushrooming, so actual measurement will be very large. That's why I was waiting for this point. Okay, continue.
Yes. Sir, in contrast, in a CT scan, sir, there is approximately 12 by 14 centimeter in size defect is present, from which transverse colon and pylorus of stomach and mesenteric fat are herniating out. There is no sir, there is no evidence of small or large bowel obstruction noted. The abdominal cavity size volume is 10,810 and hernial sac volume is 531. Tanaka index is 5%. The width of right rectus and
That is
left,
what is significance of that.
sir, sir, it means that there is no significant loss of domain.
So by this, what is the loss of domain when the Tanaka index is more than what?
Sir, if Tanaka index is more than 30%, it will be called as, sir, loss of domain.
25. So Tanaka's index is 25, Sabak ratio is 20% as per published guidelines right now. Just keep that in mind. See, there is no magic figure beyond which the person lands up having crazy loss of domain. I have landed up closing patients with 50% Tanakas also without any issues. And there are patients with 15-20% Tanaka that, make you start sweating in the middle of the surgery. It's a mix of how wide the defect is, how much soft tissue loss there is, what volume is out, and what the patient's abdominal wall compliance also is. Like male patients, for example, particularly who are young or middle-aged, are very problematic to close even like medium-sized defects. Whereas when you have a multiparous female patient, particularly who is a little elderly, the compliance is a lot better. So just I want to put this in context is that there is no single definition beyond which component separation will always be required and below which the case will always be easy. That is not why these parameters are there. The parameters are just there to give you a thought process that this is slightly, say, beyond my capability. I need help. Little pre-op optimization is required. I need to speak to my anesthetist beforehand, all of that stuff. So it's very nice that the CT scan report is having all of these parameters, but you should not dwell upon them too much. We always insist in meetings, and I especially am very OCD about looking at CT scans ourselves before we go in for these cases. So, from a surgeon's point of view, what lands up becoming the most important thing you look in the CT the morning of surgery itself?
Sir, sir, I will be looking at the width or the size of defect and
Size of
width
defect
of.
तो आ गया ना पूजन. The morning of surgery, what are you looking at the CT scan for?
Now the size and width and gone now that you must have seen before.
Anesthesia is given.
Hmm.
Patient is
Yes,
about to start. One thing that you look at the CT for.
uh, sir, sir, where the defect is ending, so that we can open from the virgin place.
All right. So close enough. It's not where the defect is ending. It is wherever it is safest to do entry.
Entry.
So any place within a hernia, say you have a full length post-mortem scar style hernia, okay, and you have to do an entry there only. So you'll figure out, okay, there's omentum over here. I will enter here, or I can see a little bit of falciform in this area. This is a safe point of entry. And you actually do a mini laparotomy of about 2 to 3 and like 3 inches is what I would say. Because by chance, in the first few minutes after entry, you'll end up having an enterotomy. An enterotomy is the single biggest intraop complication that can increase the risk of SSI, recurrence, and death. Right? So, say in the first 10-15 minutes, you'll end up having an enterotomy, you still have an option to repair the enterotomy, just close the abdomen as is and come out. Don't do any repair. Live to fight another day. But imagine you've committed to a full length incision in a 20 centimeter odd hernia. वो बंद कैसे होएगा फिर once you have the enterotomy? So that's why I was saying, look at the CT yourself, figure out where you want to enter. If by chance you have a virgin plane, great, enter over there. But sometimes that luck would have it now, even the virgin plane has adhesions inside. It turns into an absolute rubbish mess. I was recently part of a case where there was a mid-abdominal hernia, but the patient also had undergone a fan and steel incision in the past for a C-section. The entire lower half of the abdomen was plastered. So worst place to actually have an entry. So these all things become very, very apparent by looking at the CT scan ourselves. If you're not able to see a fat plane between the bowel and the abdominal wall, more likely than not, it is stuck over there. So we don't go there. Momentum is your friend. So that's the first thing that you'll end up attacking in these patients. And you do not get this information from sonography. You get this only from CT. So that's why I said on the morning of surgery, you have to go and review the scan once to figure out where to start. Could you go to the next slide?
Yes.
This we've landed up seeing. You can go ahead. Dr. Ramana had mentioned this. You should also get your radiologist to give you a sarcopenia index at the end of these cases, just from an academic perspective also. See, elderly patients will always have sarcopenia, but as a part of your record keeping and trying to estimate what the likelihood of complications is, I feel sarcopenia is quite a good indicator in today's day and age. And it's been replicated a lot in GI and HBB and transplant surgery as well.
And it's part of your routine management in terms of prehab. Rehab has become such a big word nowadays, and one must talk about it, especially when you're talking about this kind of hernias, because we are going to be talking to the anesthetist, the nutritionist. We are going to be taking a walk. We'll be beginning incentive spirometer. So just looking at the CT scan and just thinking what you're going to do in terms of anterior, posterior. I'm not very sure what you have in mind, but in terms of we need to. It is a big word, prehab. So we need to involve team members in this.
Okay. In continuation of madam's comment, I would ask you, what are the things you will explain to the patients and to the anesthetist before going for a surgery in such cases?
Sir, before surgery, I will explain patient of sir. There can be chance of sir elective intubation post-operatively. And also patient may develop respiratory complication. Sir, I will tell patient about this.
And with anesthesia?
Sir, with anesthesia, sir, uh, I will advise them to tell us when plateau pressure is increasing while closing the defect, or while keeping it nearing to while keeping the edge of both side near to each other.
I didn't get you. I understand what you want to say.
Sir,
No. Yes, Sam, you are going to say something?
No. I was just finding your comment a little funny, like bhavna samjho.
Yes.
Pujan, we can mention things like ETCO2. You can be a little more open because you are the one who sees it more than what we do. I mean, as residents, you'll are, so you can mention such words. It's okay.
Yes, that's what we are now discussing. That I am saying bhavna samjho, I can understand. So be more specific. Go back one slide.
Yes, sir.
Did we discuss carbonyl index?
No, sir.
Yeah. So why did you mention that specifically?
Sir, because sir, carbonyl index is sir 0.9. Sir, it is less than 2. Sir,
What is, in a broad spectrum, what is the importance of carbonyl index?
So carbonyl index tells us whether both the age will be.
So it suggests these particular suggests there is a wide separation of both ages in a broad term. So what is significance of that?
Sir, it will advise us whether to do component separation intraoperatively or not.
So in broad term, it will be difficult to bring two ends together. What else will you see in context of carbonyl index in CT? We have already partially discussed it. Denervation and that. What will you see? That will give you some idea.
Thickness of
Very
both
good.
the
Yes.
recti.
Thickness of rectus. What else?
And also, sir, thickness of transverse abdominis muscle.
Very good. Because you may have to plan some closure methods. So this becomes also important. So have you seen it or mentioned it?
Sir, I have not mentioned it, but sir, I have seen, sir, it is thin, sir, comparatively.
Thin to compare to what?
Pujan, there are just three muscles to compare out there. Obviously, not the rectus muscle. There will be external oblique or the internal. So,
Ma'am, sorry, ma'am.
Ahem, are you there or you have left?
Yeah, I'm here, sir.
Okay, so you are leaving. So do you want to have any salient features? Would you like to say anything?
On the CT scan? Are you talking about the CT?
Yeah. Anything that you would like to?
So I feel very important to set a few ground rules. One of which would be that the defect width, you have to take the maximum defect width wherever it may exist. Could be super top of the abdomen, could be middle of the abdomen. So pick the medialmost part of the rectus muscle on one side, medialmost part of the rectus muscle on the other side. Never consider the fascia to be within this definition, because I can tell you a lot of these chronic hernia sacs, they land up looking very dense on CT, but at surgery, you'll realize they're actually of crappy quality. So you can't really use them for your final end suturing. So don't consider any part of the sac within this. If you have multiple defects, consider the outer edge of one and the outer edge of the other. So again, go as big as possible in final measurements. Try to look for asymmetry between sides. And in my view, I am more scared of enterotomies. So I just look at the bowel and the sac interface very, very close. When you have fat in between bowel and sac, that's great, easy to do. When you don't see any interface, and this is particularly true of patients that have a past history of a burst abdomen or secondary suturing and all, where the bowel has just directly come into contact with the subacute tissue and not enough time has happened for peritonealization. So it is directly stuck to the fat over there. So the inflammation and the subsequent fibrosis that happens in the post-op period is very, very dense. So in my head, I just keep looking at adhesions very, very closely, which is again why we should not rely on the radiologist too much. This is more a surgeon's perspective and eyes that only we can look at and say that it seems to be really bad over here, or it's going to be an easier place to enter from this zone. Very important to look at the scans ourselves. Beyond that, volume ratios, I feel we overlook volume ratios a lot of times, and like the AWR community only in early on was very, very reliant on volume ratios as a barometer. But over time, we've come to realize it's only a small part of the uh, contributory factors. It's not all encompassing. Some patients are very forgiving. I have a feeling that this patient particularly will be very forgiving just because of the way that the obliques are very nicely stretched out. And yeah, that's about it on
Yeah.
CT. Really.
So may I add something to that?
Absolutely, sir.
So as this is the one more point you should keep in this mind is this is the patient who didn't have any hernia surgery attempt. That makes it very, particularly CT scan in whom the hernia surgery has been done, then whole equation changes. Because then the previous try, site of mesh, use of the plane, and that makes it very complicated and difficult. In this patient, we are having. So when you are talking of CT scan, there is a difference when it is a you can go only one surgery was done, and the patient who will have a multiple surgery even for try for hernias and recurrence, then the CT becomes even more important. In this patient, the more important, as Aham has said, is definitely look lying of the bowel. So there is a difference in reading of CT scan when it is a primary surgery and multiple surgery that had been done. Because then your approach will be different. You have to plan more meticulously what you are going to do. Because the previous surgery might have been done in which plane, maybe a laparoscopy, maybe extraperitoneal, maybe intraperitoneal, maybe rectorectus, or even in rare cases, only mesh must have been tried. Then it becomes very difficult, and it becomes very difficult to differentiate between actual muscle and thickening of the mesh. Yes.
and also one small thing about what we had already said earlier, okay, one just talks about routine investigations and most importantly about CT and along PFT. If the PFT before the CT or around the CT, if you think it is deranged, then you have to consider the fact that less is more. And if restrictive lung capacity, I think a definite no-go out there in terms of management, because she has 76 years of age. She has had a good life for 12 years. And I don't think we need to intervene and do something worse to her life, or not necessarily life, but her quality of life rather. So one needs to take a good call about just 2 investigations, a CT scan and a PFT. The rest all are just part of just routine. Not even talk about them. That's what I would say.
Okay. So, considering all these things, and we should learn now what actually you will do in this patient. We have done PFT, we have optimized the patient and given the respiratory exercise and this. Now, what will you do?
Sir, I will like to do sir, retrovertebral mastoplasty with bilateral transverse abdominal release in this
So,
patient.
you will opt for a open surgery. Why?
Sir, because of wider defect. Sir, because of wider defect, sir, I will go for sir open
How
surgery.
much wider? So, let me, I think he has left, but thank you very much. The point is that you need now some kind of classification which will help you to decide the type of surgery. So, you know the classification.
Sir, sir, accordingly, incisional hernia classification, sir, if the width of
What is
width,
that classification known as?
sir,
EIH or something like that. You must read. I often cannot remember all the point, but which is very.
The European classification is very important.
Yes.
How to quantify it as terms of ventral hernia, lateral hernias. So there is a lateral, and also the width. And here the width is more than 10 centimeters, W3.
Yes,
so
sir.
Yes.
It's a complicated hernia, and we need to factor in that. And also the fact that when you're doing laparoscopic surgery, we would not be able to carry out that much of expertise in terms of the posterior component and the expertise that is available generally. So in that terms, I think we can safely say that you have to offer an open, and nobody will question you. Okay, you go for lab, because there are very few pioneering centers, and maybe you can count them on the fingers of both your hands. The kind of surgeons who are probably doing this kind of very niche repairs, only laparoscopy. So that's why you're safe. Just quickly, can you tell us, because we are running Pujan sir, so can you just enumerate the repairs that you know about open in terms of just names?
Yes, ma'am. There are onlay, inlay, sublay, and underlay.
What is Mila repair? What is Milos? What is E-Milos?
Milos, ma'am, minimal minimal incision, mini or less onlay surgery, Milos. And Milos means endoscopic mini or less scar onlay surgery. And then for LIRA, it is laparoscopic intracorporeal rectus aponeuroplasty. And
just a quick understanding about what you want to do in terms of what these repairs mean. What is your understanding of it?
Yes, ma'am. Ma'am, in case of Milos, ma'am, I will put approximately 2 to 6 centimeter or 6 to 8 centimeter incision on the hernial on the hernial sac, and I will dissect via open method, and I will reach the retrorectus plane. Then, with the help of laparoscope, laparoscopic instrument, I will further do dissection and put retrorectus and put. And will put the mesh in E-Milos. I will also use the endoscopic instruments apart from laparoscope instruments.
Why do you want to do this? Why do you want to do a mini laparotomy and then use this? What is the idea behind it? What is the rationale behind it?
Ma'am, it will decrease the morbidity and perioperative morbidity.
Also, the neurovascular planes will be hopefully well preserved, because otherwise, if we're doing an open, we have a large incision where we are going to do a extraperitoneal, and where we higher chances of the neurovascular bundles being injured, or that by doing only going through the midline and then going to the planes below it, rather than taking a large incision and then creating planes.
Skin complication will also be less because of that. That will help. But the disadvantage?
Sir, it will need it will need, sir, expertise, and also, sir, there are more chance of recurrence.
So how is it different from SCOLA? SCOLA is total laparoscopic, no incision. Just remember that. It is again only plasty, but it has the main point is to preserve the skin. Many a time there will be a skin which will not be a normal, and if you open a large incision, chances of skin complication, blackening, and that will be more. So there are certain indications for that.
Yes.
Madam, would you like to add anything?
Would you prefer an anterior approach, an anterior component separation, a posterior one, or a normal play for this particular? She's 76 years old, very poor tone, abdominal tone. And I think Dr. Ramana mentioned it way ahead about whether we should go ahead and do it. But because we are surgeons, I don't think I can say I will not touch her. But if you want to, what would be the best approach? Because she's got a poor abdominal tone. You can see on the CT, there is not much loss of domain. There is no complication whatsoever. I'm assuming she has good PFT. So what would be your terms? Would you want to offer her a very advanced thing like a TAR or a posterior component, or just anterior and bridge the defect? What would be your mindset, or what would be approach?
Ma'am, ma'am, it will be on intraoperative finding. That
But Pujan, madam has given hint. Can you see this CT plate you have put? What is the
yes.
status of lateral abdominal muscle? You can see that the type of muscle. Where will you do a TAR? It will be a very difficult. I think so. Particularly even though patient had not been operated previously. There is a definitely you can see that quite half of the abdomen you can see. Yes, madam.
I completely agree. TAR is a very larger procedure to offer. In terms of what can we do later if TAR doesn't work out. So TAR should be the last resort always.
Ma'am,
And I would think bilateral anterior components are just try to get the midline together. I would prefer that approach because it is less damaging to the patient. And then you can cover it with a light mesh. Really, those because she's bound to have bulges. You do bilateral anterior component separation. I'm assuming that you know the areas of component separation.
Yeah,
But
yes, he must be. He
must be. We are not going to technicalities of it, but a anterior component separation. Then you just lay the entire macroporous mesh. I would think I would be doing that, and then leave a negative suction drain, Romovac on that, so decrease the seroma chances. I think I would go with that.
Madam, what madam is trying to say is, do bare minimum. What you have said, TAR is not a wrong, but it is not may not be optimum. It should be the last resort. Yes, per operative decision will have to be taken if you find a good plane, and that is fine. But what madam has said is good. Is there any other option?
yes, sir. Sir, while dissection, I will preserve the sac and can do, sir, peritoneal patch repair.
Peritoneal flap is another, you can do that. Definitely, it is now sometimes working out. And particularly when you can see the peritoneum is quite thick and can be used. That is the one more thing you should keep it in mind. The best part in this patient, what is important is there is no loss of domain. So if you can achieve the closure, your job is done. So TAR should be the last thing we should do. Apurva?
Just a side note. Midline incision, sir, can we do a shoeless plastic?
Sir, as it is partial reducible, sir, we cannot do, sir.
Absolutely no. Absolutely no.
Yes.
It should be completely reducible hernia. There should not be any content projecting out. So definitely no. And it is a too large and mushrooming is so much, particularly in a case of for a shoelace, mushrooming should not be there. So you can invert the sac very easily. So that is another important point of mushrooming. So shoelace is out of question, definitely.
Also,
Achana, ma'am? Yes, ma'am. Yes.
About biological meshes, just you should have an idea about it because introp, if you have an issue, then what are the names of the biological meshes? Not that you should know, as Dr. Ramana and Ahem, I think they're both left. But if you talk to them, I think there'll be a vast area of discussion that can go. As a general surgeon, I feel that we should talk to the basics only, where the patient requires it. The less amount of thing will take care of her life, quality of life, rather than going into technicalities about TAR or those advanced laparoscopic surgeries and biologicals. But you must know these things what are being discussed. That's all, from my point of view.
Yes, ma'am. Ma'am, they are decellularized collagen-based mesh, which are retrieved from porcine or bovine.
Though Dr. Ramanna seemed to disagree earlier, I would, as a general surgeon, I would still think that when we talk about terms of prehabilitation in terms of walk, getting the chest improvised, things in an Indian scenario, because I don't think we can talk about GLP-1 inhibitors right now. It's just very recently in the market, approved only a month ago. So in our scenario, in our country, to talk about, getting the weight down by drugs, that's a very see. There's no end to this topic. Uh, Incision hernia is a strange topic to discuss. It can go anywhere. But as a general surgeon, you're going to give your MS exams right now. So one enough to talk about component separation, your PFTs in terms of your what can what less you can offer for a 76-year-old female, who's got a very sedentary lifestyle. If you have a laborer, then we can talk about the cylinder to be maintained and your transverse abdominal stone to be coming into play. And so one with also kind of patient that with a daily wager has a different way of management. A corporate person will have a different way of management, and a 76 with poor abdominal stone with a sedentary lifestyle has a different way of management. And that will be very, very important in terms of what you can offer to the patient.
Poojan, madam has asked one question. Anterior
Yes.
component separation. What is that? What we always understand component separation means posterior. It is not always. TAR is a posterior component separation. What is anterior component separation?
Sorry, in anterior component separation, we put in vertical incision approximately 2 to 3 centimeter lateral to linea semilunaris on external oblique muscle, and we bring the medial aspect of that release external oblique muscle to form new linea alba.
And you should try bilaterally if possible. Bilateral so that there is no bulge side. Once you do it, you see a little bit of bulge. And lately in our unit, we are doing a lot of anterior component separation. TAR is reserved only for the ones who have already done surgery in the past, and it's complicated resort. So anterior component separation is a very good thing to offer the patient surgical management, especially this particular one, 15 centimeter, 20 centimeter defect. And one must think in terms of bilateral. So symmetry is maintained. There is no ungainly bulges. And one must think of putting a macroporous or a mesh to cover this bulge that is there. Otherwise, patient will feel loose hai, hernia is in the midline, but side se kuch aa raha hai. So, you have to take care of that. And I think this anterior mesh is a good option. So people say we should not, but I feel we should cover it so that we get a tone to the body.
Right. PRM, sir. Ajala, ma'am.
I think we have discussed all the points.
Right, ma'am. Right. Pankaj bhai, anything left out?
Just quickly, what complications do you anticipate and how will you overcome it? I'm sorry.
No, you are very good. Very, very, very perfect,
what
ma'am.
complications you anticipate quickly in 2 minutes and how will you overcome it? That's it.
Ma'am, I will anticipate abdominal compartment syndrome in this patient, and immediate postoperatively, and I will tackle it by keeping the patient electively intubated and sedated, and by routinely measured and constantly measuring intra-abdominal pressure.
We know all the theory. This don't go into. Suppose you do encounter it. What are the quickest thing you will do? Will you let the patient be on a ventilator? How will you intervene when you have this kind of you have a mesh out there? How are you going to intervene? How will you get the patient out? Immediate. Take a call. Quick calls. Quick decision making.
Ma'am, first of all, I will also I will sedate the patient and also paralyze the patient.
Mesh out there. Would you want the mesh? Have a mesh which is onlay, just under the subcutaneous tissue. Would you want to do anything about that? Release the pressure anyway?
Sorry, ma'am, I don't get it.
Do you want to release the pressure? You have taken some suture. It's very tight. So one thing is putting on pressure and putting them on long-term ventilator is fine. But one can sometimes think about releasing whatever incisions you have taken so that the abdominal compartment, you can live with a hernia again, right? But you cannot live with a bad chest for a longer period of time. So if the patient is not improving with pressures, with the volume, complete paralyzed, then one can think of intervening and just taking away those sutures that are keeping in the abdominal tense. That is what I would do. Salvage is important.
Yes.
Also think of what is bridge mesh.
Sir, bridge mesh is a type of inlay repair. It is replacement mesh plasty. When anterior sheath is when after closing the posterior sheath, when anterior sheath is not approximating, sir, we use another mesh to bridge it.
So it's a kind of repair which can help you, particularly when you are trying and it is not closing and component separation may not be feasible. Particularly, it is a kind called extension of anterior component separation. Either you do anterior component separation and close in midline, laterally you can put a mesh or may not put a mesh. Similarly, that's why it is known as a bridge mesh, when you anterior sheath is replaced by a mesh, which can be useful, particularly when PFT suggestive it is very bad. In those cases, it can be of use.
Just a quick question about, do you know things about stitch trial or how to prevent incisional hernias? What are the ways of, what kind of abdominal closures would you aspire to as a general surgeon to prevent this kind of, problem that we have encountered in terms of midline closures? So any idea about stitch trial, or you have
Yes, ma'am. Yes, ma'am. We should follow the technique, the Israel technique, which suggests that to use the monofilament delayed absorbable or non-absorbable suture in continuous manner with from edge it should be 5 millimeter in distance and it should be 5 to 8 millimeter apart, and with
Just quickly,
intermittent.
sorry, Poojan, to interrupt you always, but it should be less than 1 centimeter. It doesn't have to be 5 to 8 is what they say, but less than 1 centimeter in height and less than 1 centimeter away from the midline is what.
Yes, ma'am.
Yes, continue.
And also with the intermittent aberdeen knot, and it should be closed in a single layer.
Okay, and not too tense. Even when you are putting a knot, it should be not very tense. It should not be eating up on the muscle or on the sheath.
Yeah.
Yes.
Anything else apart from closure? Nothing else. Only closure is important for prevention of incisional hernia.
Sir, in postoperatively, I will also advise patient not to lift weight or not to do strenuous exercise.
Respiration, very important. Respiratory care is very important, which will prevent the increased intra-abdominal pressure or that. Judicious putting of a drain, right?
Yes.
Early mobilization, mild exercise. There are so many factors you should keep in mind. Apart from this very difficult question, these small things can be asked in it. Apurva, I think anybody would like to ask anything? I think
we have covered almost everything, sir.
okay. So
Fine.
yes, in this patient, there is definitely a role of posterior component separation may be required looking at the carbonyl index, not for the loss of domain. And second possibility is you should always keep it in mind that rather than going for that, that is another option is what Madam had said, right?
I'm sorry, my battery completely ran off in between and I was trying to
It's
figure
okay.
out.
Okay, Madam. We had
Sorry.
just discussed, he was telling about the precaution for incisional respiratory care, early mobilization, judicious putting of a drain whenever it is required, like that.
Even things like how to close the abdomen should be taught to the, you should be aware of it. The suture length to the wound ratio, 4:1 is a better one. Suture length should be 4 times the wound. And that's how you can make the connection between, 1:1. So these are all very important points to prevent incision hernia to happen in future.
Yeah. And any final points, ma'am? I think
we've covered up almost everything. There's no end to it. There's too many things to discuss. There's no
you
end
can
to
go
this.
on discussing, but
Yeah,
yes,
we
it
can
was a good
discuss a whole
discussion.
day.
Thank you.
Yes.
Thank you very much, madam.
Okay. Thank
Well
you.
presented, Poojan. Well presented.
You all and good day.
Thank you, madam. Thank you, sir. PRM, sir.
Thank you, sir, for having me over. Dr. Pankaj Modi, Dr. Apurva Shah. He was our inspector once upon a time, and thanks to you, sir. I got 10 seats, so I must be, we are all interconnected. Aham, myself, you. So
Yeah.
thank you so much.
Thank you very much.
Good night. Good day. Good day.
Good day.